Mm. Hello, everybody. Let's see how we're doing on time. 10:03. Well, maybe we should get started. Jump in. Okay, well, hi. Hello, everybody. Welcome back, or welcome in the first place. Today we're going to talk about palliative care and deep dive, meaning like, maybe beyond the sort of surface answer what palliative care is, but we'll see how it goes. These are always conversations without very fixed plans. So we'll see. But today we have a returning guest whom I know everyone loves, Dani Chammas, myself very much included. Dani, welcome back, Mama.
Thanks. I'm excited to be here.
Goody. We love having you. Really, you're just yes, for so many reasons, including the crowds love you. Well, awesome. It is so fun to meet people who know you, Dani. It is such a joy for me to watch their face light up when they hear I know of you too. It's very lovely. I hope you get to feel those vibes swirling around you in the world.
That's awesome.
Yeah, well, truly. So everyone, Dani is a psychiatrist. She's a palliative care doc. She's just a wonderful mother, artist, person. And you and I, Dani, have been dancing around together for many, many years. I don't know when the first would have been. I don't know, 10, 15 years ago. I don't know, a while.
When I was a medical student.
Yeah. Yeah. So
I know if there was a slide on like, how did you fall in love with palliative care? I would have a lot to say about you, BJ.
Sweetheart, right back at you. We feed off each other, always have. So anyway, it's really nice to be here with you. Thank you for doing this. Okay, guys, so real quick sort of level setting, safe place to think and feel. That's the gist here. Dani and I will go over some slides to level set, and then hopefully we'll have a good 20 minutes plus to do conversations, Q&A, whatever, questions, whatever comes up, comments. And people out there, you can participate. You don't have to, of course. You can just listen. That's cool. If it's just basically the only rules are be kind, and that's about it. But let's also get Sonia in this conversation here. Sones, are you there?
I am here, echoing all of BJ's thoughts about you, Dani. Thank you so much for joining us. We love having you. So as BJ said, he and Dani are just going to go through some level setting slides about palliative care. And then after they get through those slides, you are welcome to ask any question or share an experience you have. And you can do that in two ways. You can click the raise hand button and we will unmute you and you can ask your question out loud. Or if you would prefer not to do that, you can click the Q&A button and type it in and I will ask it out loud for you. The other thing you can do is put your thoughts into the chat as people are speaking or commenting and you just want to share something. That's open for all as well. Thanks so much for being with us.
Okay, thank you, Sones. And as always, credit to Sonia for zillions of things, including the slides, which as you'll see are very beautiful. Thank you, Sonia. Okay, so Dani, let's go. Let's see. So let's start here. What the heck is palliative care? It is weirdly hard to define.
Yeah, we haven't gotten our elevator pitch down at all.
No, not even a stairwell pitch. No. I've been really trying for a long time. I know you have too. And it just resists. Which I have some theories of why it resists understanding. But let's start. So there are many definitions. If you were to Google what is palliative care, you'd probably find the Center to Advance Palliative Care's definition, the World Health Organization's definition. They're all related and they are a little bit different. This is Medicare, the Center for Medicare and Medicaid Services definition. And I like it just because there's plenty to ping off of here, but let's just let everyone read it. And we'll discuss. So, yeah, well, it's a mouthful and it's clearly 2 paragraphs at least to get the gist across. But you'll see a couple of things to start us off here, Dani. Like one is what you don't see, what often happens with palliative care is it gets conflated with hospice, which we'll talk a little bit about, but hospice is its sort of older older, smaller cousin or something like that. And we'll talk about the distinction. But so often the refrain with palliative care is, oh, he's not ready for, I'm not ready for palliative care, meaning I'm not dying or I'm not ready to think about dying. But you see in the definition here, there is no reference to prognosis or time left on the planet. It really, we include death in our watch, in our care, but it's not about death. And so often people wait way too long to invoke palliative care, and therefore they suffer much more than they need to because of this misunderstanding. So anyway, there's some words. Dani, anything
No, I
else?
mean, I agree. I think there's almost like a magical thinking that goes around palliative care, and people hear the words palliative care and it's as if it means that their illness is more serious or their fate is more grim, or they think about death, they think about the Grim Reaper, and it's so interesting to me because that's not how we think of ourselves at all, right? Like we think about life, we think about going on a roller coaster and like flinging your bra in the air, whatever it is. Like we think about the living piece is so deeply important to palliative care. And so I think that the barrier number one is just getting past this huge, not for everybody, but for a lot of people, this huge sort of baggage that the word holds that we don't necessarily see as part of our identity in someone's journey.
Yeah, that's right. Every time I hear the word invoked, it's almost like you're waiting for some music in the background to go like dun 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 dun, like oh, palliative care. It's meant to be this heavy thing that like plunks down. Like it's the palliative care moment, and it has all this meaning to it that isn't necessarily there. So there's all this projection around the field that, and much of it is not deserved. And so, I one other theory here is it's also, rather than revolving around diseases, palliative care is trying to get to the person with the disease. The disease is, in a sense, incidental.
Yeah.
And very often in the rest of medicine, the feeling is kind of the opposite, that you as a person a lot of your personhood might feel kind of in the way or incidental with a lot of the curative intended treatments. Palliative care is we're trying to kind of swing that back a little bit, say, no, it's the person first. Details, variations on themes of illness or trauma or whatever else are important, of course, but they're not the point. Mm-hmm. So that's a big distinction. And I think one of the things is the public for us, I think we would all assume that healthcare, of course, it revolves around the person. But so I think one of the reasons why this doesn't get picked up is because it sounds like what all of healthcare should be. Like to an unwashed eye, if I saw this, I'd be like, yeah, duh, isn't this what healthcare is about? Aren't all my doctors worried about my suffering, et cetera? But not so in the medical model.
Well, and I would say like palliative care has been around for a little bit now, but so it feels somewhat common nowadays, but it really is a young field, right? It was very innovative when it came out. And I think for just this reason, that we have so many evidence-based ways to make decisions in medicine, and they're very algorithmic. Somebody of this age comes in with this symptom, these are the tests you order, and this is what you do with them. And you would expect that every doctor, nurse practitioner, provider would follow the same algorithm. That's how medicine is sort of built. And palliative care, like you said, it was pretty impressive the way when it was born, it flipped that on its head. And it said, no, the blueprint lives within this person, right? The algorithm doesn't exist yet. So I need to get to know the person in front of me to even have any sense of how this decision tree will flow. And that was not just novel, that was, completely shattering to the paradigm of medicine in a beautiful way. One of the things I love.
Yeah, me too.
Can I interrupt you guys? Sorry, there's just a question that's so related exactly to what you guys are saying right now. This person said, so for example, my sister who has Parkinson's disease and still is able to work and do most activities, would palliative care suit someone like her, or someone newly diagnosed with breast cancer who has a good prognosis? Is palliative care useful for them?
Like they're feeding us with the question. Yes. I mean, those are great examples. And it's interesting. I just had an oncologist. She called me to tell me about a case. So it's not even, there's a confusion about palliative care everywhere because we've worked with this oncologist a lot. And she said, this might not be a palliative case because this patient has a really good chance of surviving. And I had to bite my tongue in the moment to be like, oh no, how have we not gotten this across to you? So many of my palliative care patients got an early diagnosis of breast cancer. I helped them through the experience of their cancer treatment, And then they graduated and they moved on, and I was so happy to be with them. Similarly, like you said, Parkinson's, neurological disorders, ALS, a lot of things like that. There's a lot of progressive loss and suffering that goes on from a very early point. And the sooner you have palliative care on board, the sooner you have somebody who's thinking, while other people are worried about a lot of stuff, I'm going to worry explicitly about your quality of life, the better your care is going to be.
Right
I
on.
don't know, TJ, what you're...
Oh yeah, amen. I mean, but I think we could probably spend hours on just this slide and riffing off it, because it's exciting, I think, for us. I mean, guys out there can probably tell Dani and I love our field. It's like exciting we even love the definition of our field and what it represents. There's a, not to be dramatic, but like you're saying, Dani, there's something revolutionary in all of this. But back to that good question, absolutely. I think, so try to kind of get off this notion of prognosis or time left on the planet. That's important to the experience, but not important to qualifying you for palliative care. I mean, I think the basic gist is, if you're struggling more than you think you need to, if you're really struggling to find meaning in any of this, or kind of cope with any of the fallout from illness or the treatments for illness, or if you're really struggling which way to go and you need a safe place to talk something out and think something through, to make, big time decisions about, chemo, no chemo, whatever. Those are the kinds of things that palliative care does very, very well. Or also, the unit of care, patient and family-centered care. So even if, I think you referenced the person who asked the question, I think you referenced your mother having Parkinson's. So if I heard right,
It's sister.
Sorry, thank you. So as a family member or a caregiver, if you're struggling or struggling vicariously on their behalf, or sometimes a patient just can't get around to talking about all sorts of things, but you as a loved one or family member or whatever really could benefit from talking this stuff out, you as the caregiver, as a family member, are welcome in palliative care as well. That's what we mean by patient and family-centered care. So for so many reasons, it sounds like, yes, you would be very welcome, and your sister would be very welcome in palliative care. And sometimes, sort of like with hospice, I would encourage you to meet the palliative care guys, even, at some point. Don't need to rush out if you're not struggling with any of this, if everything's just kind of cruising along. But just, it can be very helpful to know who's in your corner and what resources are out there. So if things do hit the fan, or if a big, pain's coming and symptoms are going to need to be managed, or whatever else, it just may be nice for you to know who the palliative care guys are. So meeting them, having an initial meeting, and then maybe you don't follow up for months or a year or more. That's lovely. So gosh, Dani, yeah.
We're going to be on this slide forever. I'll say one more thing, and then we should move on. And I think we're going to go in a couple of slides into the concept of suffering, so I won't go so far. But I think one of the things that makes it hard to define what we do is that if you sat in on different patient visits in my palliative care clinic, you might think you're looking at a different specialty from one to the next, because I conceptualize myself, and I tell my patients, I conceptualize myself as putting all of my mental energy towards quality of life. But goodness, how many different things could that look like? It might be that my first patient is in excruciating pain or vomiting all day long, and we spend the whole time talking about that. And then my next patient has a tremendous amount of anxiety about, what will happen when I'm sick? How will my kids cope? So we spend the whole time talking about anxiety, right? And then my next patient might be having trouble picking which course of care to choose, because the oncologist gave them two options and they don't know which one. It looks so and then maybe somebody just really wants to get married, but they're trapped in the hospital, so I'm going to get ordained for the day to marry them. Whatever it is that is impacting your quality of life can be so huge. And I think that's why it's hard to really encapsulate for people what we do.
Right on. And that's beautifully said. I mean, I would even add another thing on the list where you don't even necessarily have to have a problem. I love visits when something's going really right for a patient or family, and they come in to share the news and be witnessed, and this is a team effort. So it can play out in so many different ways. Thank you, Dani, for those examples. We'll talk a little bit more about suffering, because there's so much to that notion. But one more thing before we get off the slide, and then I'll really stop. But I want to just note, you can see Dani and I will get excited about what palliative care can be. And we would our bias is that everyone could benefit from palliative care in one way and another. And this is a young field. We've only been, as a subspecialty in medicine, hospice and palliative medicine is a subspecialty since 2006. As Dani said, this is a return to an ancient way of caring for another person in a way, but it's also very new. And I wanted to say it's still an aspiration within healthcare. It's hard to find a program that can do all of these things for everybody who wants to come through their door. And this is a stress for the field, is how do we spool up to meet the need, especially with 80 million baby boomers aging, et cetera. So I want to note this is an aspiration. And for all of us pushing you guys to get palliative care, you may live somewhere where there isn't a palliative care program, or the palliative care program has real limits on it because usually for funding reasons, they only see certain subsets or whatever it is. So for all our encouragement and enthusiasm for the field, that we want to be realistic too, that it's not universally and uniformly available in the country. There are pockets. And this is, by the way, one reason of many that Sonia and I started mental health, which we can talk about and whatever. But all right, should I move on? Finally, Dani?
Let's do it.
Okay, thank you. All right. Well, one of the hallmarks here, guys, that makes palliative care a little special is that it defines itself in interdisciplinary terms. The subject is suffering. There's no one person, no one discipline that has a lock on what that means. So it is inherently a team sport and must be to do it well. We would make the case. So usually that means doctor, nurse, social worker, chaplain, volunteers, admin. But one thing that gets exciting to think about, once palliative care is sort of a philosophy, not just a clinical specialty, then you start getting the artists involved and architects and all sorts of, this can be a very, very big, very, very, very big table because the subject is enormous. But anyway, back to, as a medical subspecialty, doctor, nurse, social worker, chaplain, at least.
I would add like the NP, PA in with the doctor. And at the initial inception of palliative care, and this might be the psychiatrist in me coming out, there was always supposed to be a mental health specialist on the team. And I'm not sure if it was funding or what happened, but sometimes there is, and often the chaplain or the social worker has to assume that role, but that was at the foundation. And I agree, BJ, I just got an email from somebody who'd read something that I wrote, and they are on a service, they're a palliative care masseuse, but they're part of the core team at their institution. And all I could think was, how cool would it be if we all had a masseuse whose full training was just a palliative care, how do I relieve suffering mindset? And so I think we have these core teams, but there's so much potential for us to grow with art therapy. And, we have a pharmacist now on our core team at UCSF, which is so great. And just a lot of room at the table.
Yeah. I love that tension for us. I mean, again, the aspiration of what this field could be, the realities of it, there's some tension in there, but it's kind of a beautiful tension. And it's one can be really compelling to continue to try to sort of meet the mantle that we're given with this work. I
would add another piece that makes me love palliative care is I think a lot of fields now do a lot of interdisciplinary stuff. A lot of teams will have a nurse and a chaplain and a social worker. And one of the things that's really special about palliative care is that medicine is a very hierarchical culture, and palliative care really tries to flatten it. Like every member of that interdisciplinary team aspirationally has the same amount of value, of power. Their voice matters just as much. We trade off who is leading a case because, like you said, BJ, depending on the case in front of us, depending on the person in front of us, it's going to be a different skill set that most addresses their needs. And so there's not one expert on the team that's leading the others. We're all leading each other and learning from each other, which is so cool. I love what I do.
Too. And I would say, truly too, when you start thinking about this stuff, like who gets to call themselves an expert in suffering or in living or in dying? These are inherently pretty democratic notions that we all have some access point to. So in some ways, really, it can get, I I can get lost in what this could be to the point where then it's just nothing because it's so vague and huge. But really, who would be left out of this, off this table? You know, is that a phrase? Out of this table, off this table? Anyway, you get the point. So, all right, shall we move on?
Let's do it.
All right.
Suffering.
Yeah, you want to open?
Right? I don't think I told. Have I ever told you about this art teacher that I had in college named Kevin Bean?
Mm-mm.
You don't like to think that I had teachers other than you. Kidding.
I have never thought of myself as your teacher, by the way, but go on.
No, I had this art teacher in college called Kevin Bean, and he gave me literally, and I did a lot of school, one of the hardest assignments of my life. He sat down with us and he said, I want you to come up with a piece of art that is simple, but not simplistic. And for my type A, straight A, very rigid personality as a college student, it was torture. Like, what did that mean? Simple, but not simplistic. Like, what do you do with that? And yet I feel like suffering is the perfect example of something that is simple. Right? We all sort of have a sense of what it is, and yet it's so far from simplistic. It has so much depth, so many layers, so many inputs. So whenever I see the word, I think about Kevin. But I think on the one hand, we all understand this concept of suffering, of experiencing some kind of pain. And on the other hand, you know, there's existential suffering, there's physical suffering, right? There's emotional suffering. There's the suffering that comes with loss. There's the suffering that comes with indecision. There's just, I couldn't even begin to describe all the different types of suffering that exist. And it's not one or the other, right? They're intertwined and they play off of each other. Your physical pain and your mental pain are not two separate buckets. It's one bucket that's, you know, infused through your body. So.
And in so many ways like that, yes, we kind of, medicine's so good at breaking things apart and looking in pieces. And we do it too in our way, physical, intellectual, emotional. And so much of our work, I think, two thoughts. One is palliative care is to name what we've been implying is, in so many ways, it's really designed as a corrective to the system. I mean, if healthcare, if we had our way and healthcare absorbed these tenets like it seems to have in the past, before technology kind of ran away with us, and we got seduced in that it was quantity of life versus quality of life, which is just not true, et cetera. You know, this field could go away as a subspecialty if all of healthcare kind of did this work. I love that thought. We're many years away from that. But meanwhile, another thread, sorry, I'm tangenting here, but second thread is we are, as part of this sort of corrective to healthcare, we see all the subspecialization pulling people into pieces. But we not really get to see much help kind of putting ourselves back together again. And there is something about this sort of discombobulation that happens with illness and this recombobulation that happens with witnessing or with love. So anyway, just to kind of point to a couple of things in that notion, but even as we kind of piecemeal what suffering is, I just want to go back to this definition, because one of the things I love about the CMS thing is they put intellectual suffering in there, which to me, yeah, I think they're probably referencing neurodegenerative diseases, dementias, and things like that. But I also see it as how we suffer from our constructs, the things that our minds make up, the stories that our minds tell that may or may not be so true, or maybe fueling an impulse of self-defeating or self-critical impulse. But to my money, the intellectual suffering, which also gets at your concept of your mention of existential suffering, is huge. I think we all struggle so much for not just the reality we live with, but our constructs of reality that we live.
Narratives.
Our narratives. Yes, Mama. Yeah.
Yeah. Our narratives. And it's interesting that you say that, because I feel like at least once a month, maybe even once a week, I will read a case and I'll read the chart and I will have a template in my mind of what I'm about to experience. And my mind is, you know, is totally surprised by the person that I see, by the narrative, by the experience they're having of their illness that might be so different from what I was imagining the narrative they might have written would be. And so I do want to reassure people, we talk a lot about treating suffering in palliative care, but I think any good palliative care provider, their first goal is to understand your suffering, right? To understand your suffering, because we get that not only is every situation different, but every person is different. Right? We come with a lifetime of experiences, of coping, of how we handle things, of how we frame things in our minds. And so we want to know you and know your suffering before we jump forward to treating or palliating or helping with that suffering. So
Right on. By the way, maybe it's worth taking a second. I kind of love this. So everyone suffers, we all do it, but what is it? Like, do you have a definition that you use for?
Why don't you take the first stab?
Oh, that is technique. Collector. You should run for politics. Okay, so the definition I like to that resonates with me and is that basically that suffering is this wedge or this gap, this wedge that opens up inside of us that separates us from ourselves. That there's sort of this gap between the reality that we have and the reality that we wish for. Like for me, that helps. I like seeing it as a gap in me, a separation. And I like understanding my sort of basically two responses. One being, essentially quit wishing for a reality I don't have and deal with the one I do have. Contemplative Buddhist traditions would point us in that direction. But I also like that pretty taken with the other way, which is you don't like your reality, change it, too. And so I think that gives us both a way of understanding what suffering is and a way to begin to respond to it. Anyway, that's my answer.
I like it. You present it like a beautiful dialectic, and it's one that we see in a lot of different schools of therapy, this idea of how can I both accept my present and what I am and strive for different and not have one of those things be true and the other be false. That was way more sophisticated than what I might have said about suffering.
You use the word dialectic, man. Well, we should do a webinar together on dialectics, by the way.
We should. That would be fun. That would be really fun.
It would be a lot of fun. But here, guys, for the suffering thing is as painful as it is, we also are aware that so much flows from it. And it does have something with how we understand joy and how we understand meaning, is to understand meaninglessness and pain. And I don't know that that's avoidable as a human being. I don't know that you get one without the other.
And I mean, I honestly do in many ways conceptualize suffering as our pain, right? And that might be too simple of a way to see it, but it's our pain. And some of that is inevitable and some of that is not inevitable. Right. And so we will all have pain, but the degree of suffering can change and can be changed by what we do and how we approach it. So.
Yeah. Amen. Well, here again, there's a lot to say. I will say, I guess, one more thing, just to point out the obvious too, that suffering, we don't have in medicine, we love to test things, we love to objectify things. And one of the things that's so flummoxing around quality of life issues is their subjective notion. And we love that in palliative care. It's an anathema or a problem in the rest of medicine in so many ways. But suffering being totally subjective, Dani and I don't have a test to run you through to say, turns out you're suffering. Each of us gets to say if we're suffering. It is not ours to question whether or not we're suffering. We can get to know it and understand it and look at it and work with it. But just to say this is another way that palliative care works, is it kind of levels the playing field a little bit, the power dynamics. It's not doctor with special knowledge up here and patient who knows nothing down here. This subject matter has a way of being something of an equalizer.
Yeah, it's like two experts in the room, and when our powers combine,
right on,
progress together. Yeah, I would agree.
All right, girly. So let's see here. When to get palliative care? where to
Wait,
get.
do you see, okay, I was gonna say, do you see when? Because I see
So I
where.
sort of know where it was covered by the thingamajiggies there. So where to get palliative care, Dani?
It depends on your institution. It depends on where you're getting care. My hope is that in most places, palliative care is getting a foothold. You know, if you were, my best advice is talk to your doctor and say, where can I get palliative care in the setting that I'm in? Because at a lot of institutions, we have embedded palliative care clinics. You can go to a place like Metal and get some palliative care advice. But I also know there are definitely some parts of the country that don't have us there, don't have a lot of us there. There's more booming telehealth palliative care that's trying to reach parts of the country that don't have someone present. I think the bigger question is, or the bigger piece on people is, if you think this might be right for you, go to whoever your provider is and say, hey, could you refer me to palliative care? How can I get linked up with palliative care? I think this would be helpful for me.
One warning though is because of all the misunderstanding is you might hear back from your doctor, oh, you don't need palliative care. And so
So you can educate them.
Exactly.
You can be our allies in spreading the word.
Yeah, it's true enough, really. And there's a lot to be said for that as a strategy. I mean, I think we should all, as patients and family members, be aware of what's possible and advocate for ourselves. And I do think that palliative care will rise farther, faster if we in the public are pushing on it. So anyway, yes, ask your physician and be prepared for their answer, and you might need to educate them. Also, there is a resource, and we'll include this in our email follow-up, but there's the website called getpalliativecare.org that has a directory, and you can put your zip code in there, and up will pop at least the board certified acknowledged practitioners and providers in the area. So that's another way in. Or if you're oftentimes local, depends on your community, local hospice agencies will often have a sense of where the palliative care is in the program. So you can call the local hospice and ask them about palliative care, because more and more hospice agencies are creating their own upstream palliative care programs too.
There's even a lot of, at least in our area, more and more home-based palliative care, right? So for someone who's not ready for hospice, but there'll be agencies who come into your house and do the palliative care with you there, which is so great. And I will say some of my favorite patients in clinic are people who nobody referred them. They sort of went out saying, I want to start with palliative care really early. And they just pop in saying, I want to get to know you. I want you to be a part of my journey. So do advocate for yourselves, which kind of gets us to the next slide, doesn't it?
Oh, good, Dani, you're awesome. Yeah.
I mean, honestly, my answer to when to think about palliative care is now. And I say that because there's no person, I mean, maybe my 5-year-old, but in general, there's no person out there for whom you either haven't been touched by a serious illness, you don't have a friend touched by it, a family member, a loved one touched by serious illness, you're not going to be touched by serious illness. And so I think we all need to be thinking about palliative care, because as a society, as a culture, we need to change the way we think about being ill and what that means and what it is to live while ill. And so I think it's a cultural shift needed. And I know that's not what this slide was getting at, so I'm a little bit on the tangent, but this should be in the forefront of our minds, you know. And I think there is an increasing amount of people who, not that everyone needs palliative care, but this mindset of what's meaningful to me, what is important, how do I want to be living? That's a mindset that we can apply across the board at any time for any person. And so, yeah, I'll pause there.
Well, it's so right on, Dani. I mean, it's practically it's a philosophy, or practically a spiritual path. I mean, you know, if you just welcome into your daily decision making, you know, how is this, just wondering, putting it through the lens of, what does this mean to me? What does this mean in the world? You know, is this hurting anybody? Am I hurting myself? Is there something I can do here to make it a little easier for myself and someone else? Like, these are just beautiful thoughts. This is just a beautiful lens through which to see life, to approach life. So yeah, I mean, this is also the subtext in our conversation here is, yes, we want, within the realm of illness and medicine and healthcare, palliative care is really critically important and unique in the ways we've talked about. And it has purchase beyond the four walls of medicine and healthcare in this way. And honestly, I'm with you, Dani. It's and Sonia likes to talk about this too, just how it changes how you live your life.
Yeah.
It can.
I had a patient in clinic the other day. She made me laugh so hard because she was trying to decide, did she want to go to this family event or not? Did she want to do this other thing or not? And so we took all of her decisions. And I said, well, does it bring you joy? Yes or no? Does it bring you meaning? Yes or no? If not, then what is the compelling reason that you're doing it? We went through each decision. And then at the end of the session, she said, I feel like you just Mary Kondo'd my mind. But what you were saying made me think of her, and it was funny. But it is sort of a philosophy for how we approach life. But if we were to get concrete, I would say that anybody who has a serious illness or has a loved one who has a serious illness should be thinking about palliative care. And like BJ mentioned earlier, some people, this would probably be my personality because I like to have a semblance of control in this uncontrollable world, but some people will come to us before much suffering has come their way. They see the journey ahead of them. They want to know their team. They want to know their players. They want to understand what palliative care has to offer. They got some kind of diagnosis and they were at my door the next day to have me on board. And other people will wait until they're starting to suffer and it feels like the system isn't able to manage that suffering well enough. And then that'll be their cue. Okay, I think we need more support here. How about palliative care? And then other people, and this is where my heart gets sad, will come to us what I would say is way too late. They've experienced a lot of suffering. And again, we can't take away all suffering. No one's going to have a serious illness with no suffering, but they've experienced a lot of suffering before they get to us that we might have been able to, for lack of a better word, palliate, to ease some of that suffering with them. So sooner rather than later, I guess, if you're thinking about it for us, our loved one, I would always err on the side of sooner rather than later.
Yeah, I agree so wholeheartedly with that. And again, so one way to answer this question concretely is maybe at the time of diagnosis. There are programs that have automatic reflexes at the time of a metastatic diagnosis. Some cancer centers will automatically refer palliative care, and some of those automatic triggers work sometimes they don't. But anyway, I'm with you, Dani. I would say sooner the better. And even if you meet them and you're like, hey, I'm good for now, then again, you know where your peeps are when you need them. So yeah, there's something else you said that made me think of something else, but now I'm not.
For anybody listening, this is what a normal conversation between BJ and I is usually like. We riff, we forgot what we were about to riff about, something else comes up. No, but I will also say to your point, BJ, palliative care, we titrate how much you get to titrate how much you need us. I have some people who I see once a year, once every 6 months. I have a few patients I don't see it at all, but just knowing that they can send me a message is helpful. I have other people right now who I'm seeing every week, and I'm having my nurse call and check in on them 2 or 3 times a week because what's happening in their lives is so intense. And so it'll look different depending on what's going on for you.
Yeah, right on. Okay, well, I can't remember what I was going to say, so let's keep on trucking. Yeah, gosh, there's another slide we could spend a lot of time on.
Okay. I wonder.
Yeah.
Oh, I was just going to say, because earlier you called them cousins, and I thought I'm going to call them out for that later. Because they live differently in my mind. I truly think that palliative care was a big umbrella. Hospice care is in that, right? Hospice care is a type of palliative care.
I agree.
It is a type of care, that is focused on exclusively quality of life, but exclusively is what's special about hospice. So you have to qualify. You have to have a diagnosis that says you have, if we didn't do anything for your illness, you would have 6 months or less would be like a reasonable diagnosis. And B, you have to be okay with the fact that the sole focus in hospice is quality of life. So we're going to treat things that make you uncomfortable. We're not going to worry about the things that don't make you uncomfortable. Our goal is not necessarily to elongate life, although there are some studies that have shown that people sometimes live longer when they're on hospice because we're treating their suffering, and that helps them in certain ways. Whereas palliative care, traditionally is not going to be exclusively on quality of life, right? We do it side by side with all the other stuff you're doing. We do it while we're hoping for a cure. We do it while we have many, many, many months or years or however long ahead of us. Essentially, any time in the continuum, we can be doing palliative care as, yeah.
Yeah. Amen. You're right on. Thanks for the correction. Cousin wasn't quite. It's you're right on. And so it is just like you said, and I think where it gets kind of confusing is hospice kind of came first.
Mm-hmm.
At least in the modern era, 1960s, Cicely Saunders in London, St. Christopher's Hospice. That laid down all the principles that we've been talking about today, this interdisciplinary work, this focus on quality of life, all of that came to these shores in the 70s and really grew up in the 80s and became the hospice Medicare benefit. But then palliative care, a lot of people in this country were like, one, what do we do with the sort of written into the insurance regs, like this 6 months or less to live prognosis and this give up curative intended care? Those are two really difficult forks in the road for some folks. So how can we get this kind of loving support to folks who aren't yet at that stage? And I think there was a reflection in the field, like, why are we waiting until people are in their final, hours of life to be this way, to care about how they're feeling and to listen? So that's when palliative care in the 90s kind of grew up to grow around to give this kind of care a bigger foothold, a more natural foothold in the world of medicine, not just these final months of life kind of thinking. But it gets confusing because hospice came first and palliative care grew up through it to become bigger than it, to contain it. So it's just it's an interesting history. There's a lot more to say about the details, but yeah, you got the gist right on.
And you brought up earlier this idea that it used to be this idea of length of life versus quality of life. It was presented as a choice. It was one or the other. And then some brilliant people, you may have been one of them, some brilliant people finally said, why does it have to be a choice? Why can't we care about the quality of life? Why can't we care about attending to suffering the whole time? And we ended up with this field, this beautiful field.
And the very happy news about that, this quality versus quantity of life false dichotomy, is this very happy news that even if your goal is to live as long as humanly possible, and quality matters less to you, you don't mind if another hour, if I'm in pain, okay, whatever. The goals of a long life are absolutely like, you want to live long, well, tend to your quality of life too. It's part of living long. It doesn't poach a long life. It's actually part of living a longer life. And that's really great news. So this is, not only a false dichotomy, but we have it completely backwards. And even if you want to live as long as humanly possible, part of your job would still be tending to your quality of life.
And I think I've said this about 10 times, but I'm going to say it again because it's so important to me. How do I put this? I just want people to really hear when they're listening to this, that they are the driver of what is appropriate in their care. I have some patients who never go on hospice. I'll be looking at them thinking, if this were me, I would be on hospice right now. If this were my mom or dad, I would have them on hospice right now. And yet I will advocate with them to not be on hospice because the person in front of me, it would be too psychologically distressing to. They want to know that they had committed to a curative intent until the last minute. Even if there was no chance of cure, that's important to them. If it's important to them, it's important to me. And so I don't want people to think that we have a template in our mind for how your disease trajectory should go, for how your care should go. We have our own templates for ourselves, but you are the author of the template and we're here to help you write it, I guess.
That's so beautiful, Dani. Right on. Yeah, and that's such a key point. I think a lot of us, the presumption is that palliative care is a one-way street, and we are just all want you to be DNR and just get off the planet, get out
We're
of
like the gateway drug to hospice. Yeah.
Yeah, and not at all. Our job, just as I can't say it any better than you just did. So anyway, that's a really, really important point. Thank you. So that's perfect. Probably a glorious note to end on, Dani. And let's see what's going on out in the audience. Questions or comments or anything?
Yeah, we've got some good ones. The person who asked about Parkinson's and early cancer diagnosis early on when you guys were chatting had a follow-up question, and it's one we get a lot, which is, how do you then bring that up with this person without freaking them out, since it is so often conflated with dying and hospice care?
It's a really good question, because it's such a heavy word for a lot of people, to the point that, my clinic at UCSF is not called a palliative care clinic. It's called the Symptom Management Clinic. And I wasn't there when they started it, but I have to imagine that part of the reason was that was a much more tolerable wording for not just patients, but their oncologists, their other doctors and stuff to be able to take in.
Yes.
I don't think there's any one way, but I'll give you one strategy idea that we use a lot in palliative care. Is I think sometimes we'll take on sort of a Columbo explorer type of stance, as if we are learning with you, we're discovering things with you. So I have seen people come to loved ones and say, hey, I learned something so interesting today that I didn't realize before. I totally used to think that this was palliative care. And I was listening to this talk and I realized that palliative care is actually has nothing to do with death necessarily. And it's something that people are doing while they're ill, and they add it on, and it's like this added value. And some people actually live longer because of it. And I was so shocked. And so letting ourselves seem like we're just learning this as a way to allow somebody else to discover it in a really non-threatening way is one strategy that comes to mind. I don't know, BJ, what else comes to mind as a strategy?
Well, just the other way would just be directly speaking to it and saying,
Yeah.
Hey, Ma, I know, or hey, sis, just hear me out. I know this. I've been kind of tuning into this thing about palliative care, and it turns out I had it wrong. I had this sort of misunderstanding, and it sounds like palliative care is actually this sort of interdisciplinary, pursuit of quality of life, totally relevant any stage of illness. It's not really about death at all. People can be on palliative care for decades,
People graduate from palliative care.
From palliative care, and it's there when you need it and not there when you don't need it, and you give up nothing to get it, so you might just go directly sort of saying, and you can own the misunderstanding as a way to kind of soften the charge, but just simply correct the misunderstanding around the field, and that might be enough to say, well, shit, I want sorry, I want that. Who wouldn't want that? That's basically what the marketing tells us. Like, no one understands what palliative care is. Once they do understand what it is, like 92% of the people polled would want it. So it's a lot of it is just clarifying what it is and what it isn't, and then that's just an easy layup from there. Another technique would be, if that's not getting you anywhere, would be, again, leaning on this family-centric notion and say, hey, sis, I'm struggling with what's going on here. I don't know how to handle would it be all right if, would you join me in a palliative care visit just for my sake, because apparently it's helpful for the family too. And I'm struggling so taking it personally that way, and maybe bringing in the sis in the side door a little bit, that way can be helpful. So.
Or sometimes I think just describing us first and getting the buy-in, and then telling them who you're describing. I heard that there are some doctors that our doctors work with that totally focus on symptoms and quality of life and helping people through their illness. And maybe we should look into that. And then obviously don't lie to someone, right? We don't want someone to show up and us to say, hi, I'm the palliative care doc. And that never goes well. But if they seem interested in that can be a nice bridge to then say, okay, well, it's palliative care. Historically we thought of it like this, but they're actually available to us. And
right on.
I'm looking.
Okay. And chime back in, please, if there's more to say. But yeah, what else, Sonia?
Got a lot of good questions here. This person said, if the oncologist says that they do palliative treatment, is that acceptable, or should I arrange palliative care separately? I have stage 4 metastatic cancer and I'm starting to have some pain, but I'm also undergoing more treatment.
I mean, so I'm of two minds. On the one hand, we have had a very big push in our field to teach people primary palliative care, which is to say, to equip our colleagues on the front lines with a good amount of palliative care skills. Oncologists are a great example. They see a lot of symptoms and they will have more or less training in how to do palliative care. And if you're suffering, we work with oncologists, right? Like ideally we'll just add to the team, and ideally that will be their experience of it. And so if you are suffering, it never hurts in my mind. I don't know, BJ, how you feel, pulling in somebody else for the prime reason that your oncologist may be wonderful. And I'm actually so grateful to your oncologist for caring about palliative care. Kudos to you, whoever you are in the universe. But they have a certain amount of time with you, and their brain is on 12 different things, right? Their brain is on your treatment, on your cancer, on what trials you might qualify for, on setting up your infusions. I mean, I don't know your story, and on your quality of life. And so it never hurts to have somebody who can spend their entire time with you focused exclusively on that piece. And maybe it's just a consultation and we say, I would try these 3 things, and we step back and you let your oncologist do it. Maybe we work side by side with them. It'll be different for everybody, but.
Yeah. Yeah. And that consulting kind of role, that's what we do at Metal. We don't become the doctor. So we just we would coach you how to talk to that doctor versus becoming your doctor. Our model is a little bit different. But in the same way that palliative care is almost always a consulting service, and to your point, Dani, you can push that oncologist, or you can just reach out to the palliative care program and just see if they had anything further to offer. And as a consulting service within the world of healthcare, that means like usually the oncologist would be considered sort of the primary physician in that situation, and the palliative care team would be consultants and make recommendations to the oncologist, et cetera. So there's some sort of bureaucracy answer to your question too to navigate that can affect the answer to your question. But I guess I share your 2 minds. Like it may be that oncologists really did get some extra training in palliative care and really means what they're saying here. And that's not a naive statement. They really do have these skills, and they want to be your doctor. In a way, that's another way to hear that. So, one way would be to give them a chance and see how it goes. And if you're still just suffering and struggling in ways that feel, like don't have to be, then maybe it's time to say, hey, doc, thanks for trying, but is there a specialist we could involve here too? Something like that. But it is, I also say one more thing. It is not an uncommon refrain, especially in the earlier days of the field, to hear a comment like that from a physician is really sort of as a comment of not really understanding what this field is about, and not understanding just how much there is to do to quell someone's suffering. So sometimes a comment like that could be a little sort of turf oriented or a little naive. And sometimes it's just absolutely accurate. Sometimes that doctor has everything that you might need. So you got to kind of feel your way.
We do our best to be helpful, not just to you, but to the team, right? We want palliative care's presence to make an oncologist or whoever your primary doctor is, feel supported, and also feel like they have somebody there to bolster and to help and to be adding, not, taking from anything. So
yeah. A typical story in the field's development would be, and I suppose our experience at UCSF at the clinic you're referencing, was early on, Mike Rabo guys started this clinic. In the early days, there were a lot of skeptics. We don't need what's palliative care, soft stuff. What is this stuff? We've got the, there was a defensiveness, and I was around for those early days. It was fascinating to watch. Not a lot of referrals came in, but slowly, one at a time would come in. And it was very often what allowed that clinic to take off in so many ways. And I think it's probably representative of many palliative care clinics was, yes, that the patients felt better, but the referring doctor's job got easier, not harder. And after a few cases, that often was the case. A lot of early naysayers, oncologists who didn't want to have anything to do with us, one way or another, we ended up with one of their patients and handled it in such a way that and fed back to the oncologist and made her job a lot easier and made her look really good. And then before we knew it, she was referring folks to palliative care all the time. And so there's a little bit of this history of, in this field's growth of, yes, tending to the patient, absolutely, in all the ways we're talking about, but doing it in such a way that you're also helping your colleagues. And we have data that institutions that have palliative care programs are happier places to work, less stressful places to work. And I think those are related.
Mm-hmm.
So
Okay. This is another biggie that I'm sure lots of people have a question about. Does Medicare, Anthem Blue Cross, insurance pay for palliative care?
yes, is the short answer. Palliative care, unlike hospice has a benefit, a designated benefit around it that dictates what it can and can't do. And within the insurance world, a sort of entire benefit around it is a significant statement. Palliative care, there's no palliative care benefit per se. Palliative care, the way it gets billed for is a little tricky. Only doctors and NPs can bill for this service, which makes it tricky. There are always ways to bill for it, as long as one of those two kinds of folks or PA is in the mix to do the prescribing, and bill for time. So yes, insurance covers it in this way, but another angle on your story, to get into the weeds of the back office, is that payment does not cover the chaplain, the social worker, the rest of the team. And so most palliative care programs can't make it with just billing alone in this current reimbursement model. Most palliative care programs, just like the one you work at, Dani, had to do a lot of fundraising to get off the ground to supplement what was billable. So there's a complicated answer to your question, but the short answer is yes, insurance does cover it.
Yes, for you as the patient, you should not be expected to be contributing more to this than you would to any other medical appointments that you have.
Yeah. Thank you for that.
This is a good question. What is the most challenging issue that the palliative care team faces?
Ooh.
Hmm.
I'm gonna sound like a broken record. I would say that's going to be different for every palliative care team or provider that you come across, right? And it might be different from one week to the next, because we all experience different things as more challenging than others. So just like every human, just like every one of you, every one of us is going to find our challenge spot in this work, possibly in a different place. But BJ, maybe you've got a better answer than that. I can answer for myself, but
well, I think that's what they want to hear. I think that's what the question's getting at. To us personally, I'm assuming. I mean, we can't speak for the entire field, to your point. But do you have a personal answer to that question, I guess?
I guess my personal answer to that question, and this is one of those things that is both a pro and a con of this work. I will say that before I had children and I was doing this work, I found it connected to me to a beautiful wisdom, to the truth that we're vulnerable, that tomorrow isn't guaranteed. Some of these sort of Buddhist, more enlightened notions that usually you can go through life with this myth of control and this myth of certainty, but sort of less in contact with the truth of the human predicament. And that was very empowering to me early in my career. It made me live a certain way. And then I had kids, and I experienced a different kind of vulnerability as a human. And I sometimes find contact with that truth both beautiful and petrifying more than I did. It didn't used to scare me, and it scares me now. So I will work with someone who is my age, who is saying goodbye to their children sometimes, or who is no longer able to engage with them in the way that they want to because of their illness. And for a moment, I will have to deal with the fact that I could get very sick. I could have big losses. My kids could get very sick. They could have big losses. And that's not fun for me. It was never fun, but that's hard for me. And I am working as a human on the progression of getting back to a place of finding that empowering, because it is authentic.
Right on. Yeah, thank you. Thanks for going personal there, Dani. Yeah, I think for me, and it certainly has evolved over time, but I think where I am these days, and maybe much of the time in my career or whatever, has been the pain that comes with interfacing with a system that isn't designed adequately or well as it could be to enable this craft to actually be realized. So my answer to the question are the systems issues are the things that drive me most batty, that I find most demoralizing and most difficult. and also energizing, and it kind of gets your activist hat going. And again, this field is, you kind of can't do this work without being somewhat, there is activism in it because of, we're aware of the context in which we're living and pushing against. So anyway, that's my answer to the question. And that may be kind of a sideways answer to what the questioner meant, but that's my answer.
Yeah, when you see a distress, well, it's painful to see some distress that we can't fix, but also when you see a distress that you think this could be palliated, this could be fixed, and I'm not able to do it, they're not able to experience it because of something systematic. But also a great example of, those are two very different answers, right? And somebody else who's running a service might say that the hardest thing in palliative care is that our value doesn't come in dollars, and we work in a system that values services in dollars. And so we're constantly having to prove ourselves, right? Like prove why we help the system, why we help, that might have been a totally different answer. It's just not.
Yeah, it's a good one too. All right. Sounds anything more?
Yeah, no other questions, but since we're at time, I just wanted to share this note that was put in the chat, which just also lends itself to what we're talking about. This person said, my sweetheart suffered for 2 weeks in intensive care with aggressive treatment that he didn't want, until I learned that the hospital required a doctor's order before we could speak with a palliative care doctor. There were many roadblocks with unsympathetic neurologists and neurosurgeons. So just a quick note to say that there's definitely some advocating that you may have to do for palliative care.
Yeah. Yeah, thanks for that. I mean, this gets us back to one of the sort of themes of the day, is to just make sure we remember the aspiration here of palliative care versus what the realities of it. The aspirations for our healthcare system versus the reality of it. The gap between the two can be very big, and it's no joke. And we had to hold it all. But I hear that comment is realistic, and I know this happens. I'm not at all surprised to hear that experience. And it's also what helps Dani and me and others get out of bed and keep kind of trying to do this work. So thank you for sharing that comment. And that's some unnecessary pain, and I am sorry for that.
It is unnecessary pain. And it's a reminder too, that like we in healthcare are just as flawed as everybody else, right? We're human, we're flawed. And there's a lot that goes on in your doctor's experience of you being ill and wondering what it means to need help and all that stuff. And so, yeah, I'm just sorry that you went through that, whoever made the comment.
Well, thank you guys so much. It was great, full of information. Thank you so much, everyone, for being here, and hope everyone has a relaxing, good weekend. Thank you, Dani, for being here.
Always a pleasure.
Thank you, Dani. You're awesome. Thank you very much. And thanks everybody out there. Yeah.